All right, Meg, it's 12 o'clock. Do you want to get started?
Excellent. So good afternoon or good morning, depending on where in the country you're joining us from. My name is Meg Camo, and I'm a Senior Project Director with the Center for Innovation in Social Work and Health at Boston University. And I'm also the Principal Investigator for the Children with Medical Complexity Collaborative Improvement and Innovation Network, or as it's affectionately known, the CMC COIN. Welcome to you all today. Thank you very much for joining us on our latest session of the Care Coordination Academy. We're looking forward to spending a wonderful few hours with you all, learning about social determinants of health and care coordination, and in general, improving life for individuals with medical complexity, their families, and their providers. I want to start by switching to the next slide and thanking our funders at HRSA, the Health Resources and Services Administration. I want to thank them for their support of this project. They have supported us financially. They have supported us from a practical standpoint in terms of content. They've supported us spiritually and existentially in every way you can possibly think of. So we want to say thank you very much to them for that. Dr. Warren is joining us today and will speak in just a few moments. And we appreciate him making time out of his busy schedule to be with us. Anna Maria Padlin, who is the project officer for the Children with Medical Complexity COIN, has also been enormously supportive of this project. She's been a great thought partner as we have, on sort of a very short timeline, developed, implemented, and are now carrying out the Care Coordination Academy. There are several other members of the Division of Services for Children with Special Health Needs noted here who have been, again, enormously helpful thought partners to us, so we thank them for that. Next slide, please. So just a few words of welcome and housekeeping. This meeting is being recorded. The breakouts will not be recorded, as Heather mentioned. Please, when you're speaking, if you're participating auditorily, please don't use your speakerphone. It gets a little echoey sometimes. Please don't put us on hold. Some folks have hold music, and as much as we all enjoy that, it does distract just a little bit from our content. So that would be great if you didn't put us on hold using your own hold mechanism. If you do need to put your phone on hold, you can mute yourself by pressing *6 to mute, and then pressing *6 again to unmute. Please rename yourself in the little Brady Bunch square that you have there with your state team name first and then your own name. It just helps us stay organized when we split people up into breakouts, and when we're looking for groups of folks from individual teams, it just makes it easier for us to identify. You'll see that my name is an example here, so it's VU and then my name. The chat will be moderated this time around, and time has been designated for questions. So we're hopeful that not only will you get a lot of really interesting and useful and helpful information from our stellar speakers, but you'll also have a chance to make comments and add your own thoughts and also ask your questions. It's very helpful to us when you link your phone with your computer, so that again, as we're organizing participants, moving folks into breakout rooms and doing other sorts of administrative tasks, that it's easy to identify you. Next slide, please. So I'm going to pause, say again, thank you so much for joining us, and turn the floor over to Dr. Antonelli, who will share some words about today's agenda.
Thank you to my partner, Meg Camo. I want to welcome everybody to this next session of the Care Coordination Academy as well. The tremendous amount of work that's continuing to happen while all of us are dealing with the pandemic surge and the implications for that. So we hope that the Academy will continue to be a source of guidance and inspiration and positive energy and measurement and sustainability for going forward. I especially want to say thank you to Heather Pamela, the manager of the Care Coordination Academy, whom you're going to be hearing from shortly, our coordinator, Erica Norkis, and Jessica Flaherty from our BU team have done a lot of tremendous amount of work behind the scenes for today. Quick run through. In the first few minutes, you're going to hear about a new offering to the Academy, continuing education credits. In order to accommodate our speakers on the front side of today's block. We're going to give you just enough information at the beginning of the conversation about getting those continuing education credits, what you need to do to get them. We'll give you a brief reminder as we come back from the break, and then to close out, and then of course you'll be getting emails as well. But we're really excited that the Continuing Education Department at Boston Children's Hospital expedited our application, so today's activities will be available for continuing education credits. You're going to hear from Katie Huff, who's our Med Ed Director. Then Heather Pomella, Manager of the Academy, is going to provide a summary of how much implementation is happening in a relatively short period of time across the teams. I'm thrilled to then be able to introduce Dr. Michael Warren, and I will hold my thunder for that introduction, but I am giddy to be able to know that I reached out to Dr. Warren and he said, when do you need me? So we'll be privileged for that. The focus today is around social determinants of health. Our goal is not to convince people that they are relevant or that they are important. The goal is to say, here's the science, here's how you can use the science to move into implementation and measurement and sustainability. So Linda Sprague Martinez from Boston University, whom I'll introduce in a few minutes, and then followed by Renee Turchi, who's coming back for another presentation for us. We're going to only have a small break in between, but we've lengthened the team time for the breakout. That will follow Dr. Turchi's session, and then we'll regroup and have closing remarks. So that's the agenda for the day. Be free with use of the chat box as we go forward. It will be monitored, and as Meg said, we will also be opening some time for Q&A. So I'm going to hand this over to Dr. Katie Huff, who is our Med Ed Director for the Academy.
Thanks so much, Rich and Meg. It's great to be able to share this exciting news that the National Care Coordination Academy has been approved by the Boston Children's Hospital's Interprofessional Continuing Education Committee as a regularly scheduled series, recognizing the value of the content and also the value of your time that's being dedicated to professional development and applying this in your own practices. So we've listed here the professions for which it's been accredited. This applies for the sustainability affinity groups as well, and the amount of credit hours are commensurate with the time spent in participation. I just wanted to let everyone know that the committee is able to approve only certain professions based on what it's certified to provide. And so if you do have questions about that, or about why, if you represent a different profession that's not included, please don't hesitate to reach out to, I guess, to Heather as a central point of contact, and we're happy to answer any questions about that. So I wonder if you can switch to the next slide there. Thanks so much, Heather. Just a couple things that will be slightly different for today's session and for sessions moving forward. In order to obtain credit, we will have to record participation very specifically for people that wish to claim credit that fall within the professions that were presented, so physicians, nurses, and physician assistants. This also includes MOC Part 2 for those that are collecting credit. And so you'll be sent a link through the chat at some point that asks you to identify kind of yourself and put your contact information. And this allows our CME department to be able to send you an evaluation after the session. After you complete that evaluation, you will receive a certificate that recognizes that you've spent kind of the 4 hours today engaging in this discussion. You will also kind of see more emphasis on kind of eliciting intent to change and reflective statements. This could be sort of informally through the chat, as well as reporting out from team breakout discussions, but also in the post-session survey, which I think you're used to seeing coming through on SurveyMonkey. This will still be the same because we want to ensure we receive everyone's feedback, not just those that are applying for credit. But it will include questions about sort of how you might apply some of the principles being discussed to your own practice. We encourage everyone to reflect on that throughout the time today. And we just wanted to give everyone a heads up that if you have requested credit, you will get the separate evaluation from the CE department as well. And that's necessary to complete for your certificate. In the interest of time, please don't hesitate to reach out to Heather if there are more questions about this, and there will be a reminder about these requirements at the end of the afternoon. And Kara, we would love to be able to provide credit for you as well, but unfortunately, we're not able to through Boston Children's Hospital, but I will let them know that feedback. So thank you so much, everyone, for your time.
Excellent. Thank you so much, Katie. So hi, everyone. Welcome back. I hope you all had a great Thanksgiving. For anyone that may be joining us for the first time, my name is Heather Pamela. I'm a pediatric neurology nurse practitioner at Boston Children's Hospital, and I'm serving as the manager of the Academy. I'm going to share with you a brief overview of our 14-team work plans. Thank you to each of our team leads for completing this first progress survey and giving us a little taste of what you all are implementing. As you'll see here, many of you have identified that you'll be testing some process metrics. Examples of these process metrics that are being implemented include time and effort tracking through our care coordination measurement tool, also known as CCMT, and then utilization of the pediatric care coordination curriculum. Some of you selected other, which just means that you guys are go-getters and doing both process and outcome measures. Some examples of the outcome measures that you guys are doing is utilization of the Pediatric Integrated Care Survey, the PICS, and the utilization of measures from the CMS Medicaid Child and Adult Core Set. So lots of great things being put into place in such a short period of time. It's only been 2 months since the launch of the Academy, so excellent work, and we really appreciate seeing all of your work plans. So just examples of some of the interventions that are being tested across teams. As I mentioned, the CCMT has been a popular one that's being used. In addition, the Pediatric Integrated Care Survey, many of you are using that. One of my favorite tools, Rich, you know this, is the Action Grid. A couple of you are using that. We have the High Quality Handoff tool. Many of you are using the Pediatric Care Coordination Curriculum, combining it with using your other interventions. So that's excellent. And then we also have the Care Management Measurement Tool, the CMMT, not to be confused with CCMT, for COVID response. Just want to scroll down here. So everyone is doing such a great job. Those that selected other are doing a combination of a couple different interventions and some other COIN family satisfaction surveys. And then I just want to mention too that we now have the discussion forum that's live on Open Pediatrics. I'm going to use this space to be fielding some technical assistance questions that may be helpful for everyone to process together. They will be redacted, but feel free as a team lead or anyone from your team to go onto the discussion forum. If you scroll down to the Q&A section, you'll see that I did a first post to get things going, and just encouraging conversation. You're able to help each other out. There's many of you implementing the PICS, many doing CCMT. If you're having trouble with something or you want to see what another team, how they might be implementing, this is going to be a great space for us all to communicate. All right. Thank you guys so much. I hope you have a great day. I'm going to hand things back over to you, Rich.
Thank you very much. And I just want to point out, when you consider we launched this National Care Coordination Academy in September, and the amount of work that is happening across these various teams. And I want to just call out the fact that they're not all homogeneous in design. In fact, I've been particularly thrilled that we've got teams that began with the CMC COIN teams. We've got other delivery system-based teams, and we've got some of the CMMI Inc. Teams that have joined. So we want to demonstrate to our funders and to the broader community that you can implement and measure care coordination and care integration for kids with special health care needs across a diversity of populations and model design. So I'm going to go ahead and introduce a dear friend and colleague, Dr. Michael Warren. He's the Associate Administrator of the Maternal and Child Health Bureau, which is part of HRSA, which is part of the Department of Health and Human Services. I will not spend as much time as he probably deserves because he has asked me to keep it brief, and I shall. I have been a fan of this man, general pediatric with a focus on community, with a focus on public health. And he's seen families' needs from state level. I got a chance to connect with Michael when he was serving as the president of AMCHIP. And then in 2018, he came to the Bureau. And most recently, what I'm excited to share is the team from MCHB is going through a strategic planning process. And I was both honored to be part of that. Quite a few of the people on this Zoom conference, in fact, were part of that. But asking for what's next, what's next for CYSHCN, what's next for families, what's next for children with medical complexity, and in a sense, the Academy continues to be a place from which those messages can be formulated and delivered. So with no further ado, I'd like to ask Dr. Warren to come and say a few words for us, please.
Thank you so much, Dr. Antonelli. Good afternoon, everyone. Really appreciate the invitation to join you all. Just to share a few remarks from the Bureau, I do want to start by thanking both Rich and Meg and the folks at Packard for the work in convening this gathering today, but also for the really important work of the Academy and the way you all are approaching this. I think it aligns with the approach we try to take at the Bureau, and I'll talk a little bit more about this, but really appreciate the deliberate way you've done that, and also the deliberate focus on measurement as well. I also want to, before I forget it, acknowledge our team that's a part of this call and has been supporting this work. So Anna Maria Padlin, who's the project officer for our Children with Medical Complexity COIN, as well as Marie Mann, who's been involved with this work and supportive of this work for many years. And then I see Trevi Brown is also on the call, who's one of our branch chiefs who does a fantastic job of thinking about how our various initiatives fit together in an integrated way. I want to sort of start by sharing with you some of the framing we're using as a Bureau. So some of you have heard me talk about our frame of accelerate upstream together. And I think it so nicely fits the work that you all are doing. And I'll share with you sort of what each of those concepts means to me and how I think that ties back to your work. The accelerate piece, when we think about medical home, is a perfect example of where we have an opportunity to accelerate. You know, the medical home concept has been around for a long time, and I think for those of us on this call, it feels like very old news, right? Because many of us were trained, or at least early in our careers were exposed to that, and it feels like we should be doing that already, and everybody should be doing that already. And yet the reality is, when you go back and look at the data, and I just pulled this morning, I've been using these year-old stats, and it dawned on me the new national survey data is out. So the National Survey of Children's Health, which we fund, their data is out on the childhealthdata.org website. And so I went and I said, let's look at medical home. And despite the fact that this concept was first introduced in the 1960s, 1967, I believe, we went to folks at the AAP and we said, can you search your library and see when this term was first used? So it's been a long time, 1967. Despite that, so what's that, almost well over 50 years, I'm trying to do that math quick, but well over 50 years, only 49% of children without a special healthcare need report having care in a medical home. And you would think, well, it must be better for kids with a special healthcare need because that's really the population for whom this concept was introduced. It's actually worse. It's about 42%. And so we really have an opportunity to accelerate the pace of that change. And care coordination and care integration is a pivotal part of that. If you look at that medical measure, it's really a composite of all of those various aspects of the medical home, care coordination being one of them. So couldn't have a better case than this for the ways we need to accelerate. The next part of that framework, though, is upstream. And upstream, thinking about the various approaches beyond just clinical care. Clinical care, absolutely important, particularly for children and youth with special healthcare needs. It is necessary, but it is not sufficient. And so as we think about the various challenges that kids and families face, there's really an opportunity for us to look more broadly at social and structural determinants. As I was reflecting on what to say for this call, I was reminded that when I was a pediatric resident, I loved primary care clinic. And I wanted to do everything I could to get my families in. And with all good intentions, I actually did some things that were not very good. For example, I had a no-show letter that if families didn't show for their appointment, I would send to them. I thought I was showing caring and saying, I really miss seeing you. But I also said things like, you know, I can't keep your child well if you don't bring them into their appointment. What a horrible thing for a pediatrician to say. But it didn't dawn on me at the time that there might be very compelling reasons why kids and families didn't bring, or families didn't bring their kids in or weren't able to bring them in. And the tipping point for me was when I was a pediatric fellow, designing a curriculum for our residents to think about how they engage in the community and understand those various non-clinical factors. I had the experience to participate in a poverty simulation. And it was probably one of the most impactful things I did throughout the entire course of my training. I remember leading the simulation and driving back to the clinic really in tears, reflecting on how I had so missed the boat early on in those clinical years, thinking about all those various factors that were influencing whether a family made it to clinic, whether they were able to engage in healthy behaviors in their communities, whether they could even put their own health as a priority given all the other competing factors of the day. And so I say all that to say we have to think beyond the walls of the clinic and beyond the walls of the hospital where we find ourselves. We have to think about those upstream determinants. And so I hope you will learn from my failures as a clinical pediatrician and those lessons learned and how we have to look beyond and think what are those factors that we can address and support families along this journey. So accelerate upstream. The third part is together, and I think the conversation already about how do we engage families, how do we keep families at the center of what we do is so very important. When I was a brand new Title V director in Tennessee, I was intrigued that as part of our block grant application, we had to complete a form that said, how is the state doing with regards to family engagement? And it sort of felt like the fox guarding the hen house, like the state is saying how well the state is doing with regards to family engagement. And so about a year in, we had started to build some partnerships with our state chapter of Family Voices. And we didn't feel quite comfortable saying, you fill out the form, but we said, why don't you fill out the form and we'll review it. Well, the next year we said, you fill it out on your own. You tell us how we're doing, and that's what we'll report to our block grant. And that journey evolved really to being, you help us co-write the family and consumer section of our block grant and our needs assessment. Come to us or come with us to our block grant review with our federal project officer. We want you sitting at the table with us so that when the feds ask us, how are we doing? We can turn to you and you answer that question. We're not just giving that. So families have to be at the center, and they can't just be a person on your committee that you invite when you're ready to roll out a project, or that you can say, check, we had the family member there. They really have to be engaged pre-decisionally. Because my own experience and that of colleagues has been, when you ask families what they want and what they need, it's often very different than what you think they want and they need. But the important thing is, it is really what they want and they need. So keeping that at the fore and keeping them at the center is really key. So that's a crucial part of together when we think about accelerate upstream together. The other is the other collection of players that you have around the table to be engaged in this work. I know there are folks who are representing Title V programs or are connected with Title V programs. The Title V MCH programs, there's one in every state and jurisdiction, really play an important role in thinking about who are the right people to bring around the table to start to scale some of the changes that you all are trying out. How do we scale those at the system levels, whether that's the regional or the state level? Title V can pull the stakeholders together to think about how do we change this? How do we take an interdisciplinary approach and really think about moving the needle on family-centered care? States actually report on a national performance measure related to medical home. Many states have selected medical home or specific elements of medical home, like transition, as one of their state priorities. So this is something they're interested in and working on, and they can be really great partners. One of the partners they can help bring to the table as well are your state Medicaid programs. Having worked both in the clinical sector and in the public health sector, one of the things I've come to realize over the years is if you really want to make change, you've got to get payers involved. And Medicaid is such an important player in this space. And I will tell you, Medicaid is complex. And sometimes if you're not on the inside, it can seem difficult to figure out how do we navigate it. But I have met some wonderful folks in state Medicaid programs and at CMS at the federal level who are very interested in working for families generally, and particularly children with special health care needs. So having them at the table is key. So that's a little bit about accelerating upstream together and the way I think it sort of fits with the work that you all are doing. I wanted to just say a couple of other things. I think the Bureau has for a long time been interested in children and youth with special health care needs and how we support them and their families. And so investments in the medical home, investments in earlier iteration of this work that supported the development of care coordination tools, in innovations even recently thinking about our grand challenges related to care coordination for children and youth with special health care needs, inclusion of performance measures in our state block grants related to medical home and some of the sub-elements there. So this has been a space we've been in for a long time, and yet we realize there's tremendous opportunity for improvement, as I mentioned at the start of my remarks. So we are engaging in strategic planning, both at the Bureau level, but also our Division of Services for Children with Special Health Care Needs is working on a blueprint that will really guide their work for years to come. And so we will paste in the chat box the links that you can use to respond to both of those to share your input. We want to hear from as many folks as possible to really give us robust strategic plan broadly for the Bureau and a robust blueprint for children and youth with special health care needs. Just a couple of other things moving forward. I so appreciate that you all are looking at social determinants. And I know you've got, you're using a lens of equity as you look at this work. And I think that is so incredibly important. Often we talk about these national level statistics, and it's important to say that's great, but what does that mean for non-Hispanic Black children? What does that mean for rural children? What does that mean for families who are in the lower income categories, families where the parents have less than a high school education? Stratify your data. Because as we think about this drive toward equity, we're not going to get there until we really focus on who's not there already and how we move them along. And so I think that is critically important, and I so appreciate your deliberate efforts at measurement. I also want you to continue, as you think about social determinants, to think about structural determinants like discrimination and how that plays a role in access to services and quality of services that's provided, and where you all have an opportunity to be a voice and bring solutions there. And so I appreciate that you all are doing that. The last thing I'll say is the focus, even in the opening remarks that were shared with you earlier, talked about measurement and the approach that you all are taking in doing this work. It is so key. This old QI mantra of what gets measured gets improved is so incredibly important. And I would encourage you to take that next step to make sure, as you're thinking about how do you systematize this work, I don't know if that's a word, but how do you really scale this and make this move forward? I would say what gets paid for gets improved. And so thinking about how you engage payers to show them why this is so absolutely important to do. And I would encourage you, as folks who influence systems, to think about how you do that from an equity standpoint. I don't think it's good enough just to pay for outcomes at a population level, but how do you pay for equity in outcomes? And how do you make sure that if we're really going to get this kind of reimbursement for quality improvement, that it's quality for all and not just some aggregate number? So I'm going to stop there. So appreciate the opportunity to connect with you all, but more importantly, really appreciate the work that you all are doing. It is so vital to the national level efforts to improve care for all children and families. And I look forward to seeing what comes out of it. Thank you.
Dr. Warren, thank you. That was incredibly powerful, and I was struck. I could put myself in the car with you as you were driving back from that poverty simulation experience, and to feel what it must have been like to be in tears. And I feel that, and I feel that for the patients that I care for, and I think that that's what's bringing us together with this academy. So those were profoundly touching words, and we're extremely grateful for the vision of the Bureau and the investment in this process to demonstrate what implementation looks like. So this is a perfect segue to our next speaker, Linda Sprague Martinez is the chair of macro practice and associate professor at the BU School of Social Work and a research fellow for the Center for Promise of America's Promise Alliance. I had the absolute privilege of asking Linda to be a co-author of the third module of the second edition of the MCHB funded Pediatric Care Coordination curriculum. And I just want to take a minute to describe that. I was the editor of that. We had Jeff Wilkinson and Linda Sprague Martinez, social work backgrounds from BU. We had Clem Bottino from Boston Children's Hospital, a primary care provider. And editing that module was both so much fun for me, as well as demonstrated the notion of, wait a minute, where does the social work piece fit in? Where does the medical home piece fit in? And the idea of care coordination, but with the outcome being integration. So how do systems work together? Think about what is it that the families are looking for. So with that as the intro, I am absolutely honored to have Linda speak to us today. And as I said, we're not going to take any effort to convince you that health-related social needs and social determinants of health are profoundly important. That's a given. The purpose of today's academy discussion is, what do we know about the science? What can we do for implementation? And what can we do as an academy going forward to begin the process of measurement? So Linda, please step up, and we're looking forward to hearing your presentation.
Great, thanks so much for having me. I'm excited to be here with you today to talk about social determinants of health, and I think about addressing social determinants of health as a way to advance equity. So it was exciting for me to hear the previous presenter, particularly talking about equity and the role of family engagement, which is so important. Just a quick disclaimer, as some of you may also be experiencing, I have a whole homeschool situation going on, so don't be alarmed if you see folks moving behind me, as it is lunchtime. They're being diverted to another location for lunch today. So you'll see that. And then also, sometimes people are less familiar with the field of social work or more familiar with the field of social work, but there's a whole spectrum of practice. And so where I sit with macro, which is not a very descriptive name, I'll put that out there, is that macro social workers are folks who are interested in systems change that happens at the organizational and community level and policy practice. And so we work a little further upstream than our colleagues who are more clinical, who you see delivering direct care to patients. And so that's just a quick overview. You can click to the next slide. I'll also say to stop me at any time. If you want to throw a question in the chat, I'm going to try to monitor the chat as we go along. I'm happy to answer questions that come up as we go through. And then to disclose that Linda Sprague Martinez, and third person, is a consultant for the Boston Public Health Commission and for America's Promise Alliance, as well as in the last year for CCI Health and Wellness. It's a network of health centers down in Maryland. So you can click. Okay, so what am I going to talk about today, or what are the learning objectives? I'll talk a little bit about the relationship between social determinants of health, health equity, and patient well-being, just so we all have a shared understanding and on the same page about thinking about social determinants of health, and then explore strategies for organizations and communities to think about how we can leverage assets as healthcare systems to advance social determinant screening and referral systems. And I'll share a little bit about what we already know in the literature before I jump into that. So I'll click to the next slide. Again, questions, feel free to ask throughout, but I'll talk about equity and social determinants, then assessing considerations as we get started. It's a little repetition there. So just some background. Racial inequities in health are pervasive across a myriad of disease conditions. It's been well documented that the factors that both cause and sustain inequities are driven by racialized policies that create inequitable living conditions. And as such, if we're thinking about addressing inequity, we really need to take a structural approach to understanding health and well-being. As we go. And I think it's funny, you know, in my past life, I used to work way back when I worked for the Office of Minority Health through the 90s and 2000s. And if we were to look back at the literature around health inequities, we wouldn't see much literature prior to 2000. Then we saw this increase over time in our language. The way that we talk about health disparities has shifted to now health equity, and we're seeing more and more of a focus on social determinants of health. But I also want to remind us that it's not a new focus. And many of you, I saw when I was looking through the participants are coming from community health center settings. And you all have been focusing on social determinants since the inception of community health centers. So I just also want to recognize and name that. I think a lot of times today, working with students and talking with folks, they're thinking, oh, we're focusing on social determinants as if it's something new for folks in healthcare delivery. But the reality is that community health center movement was all about focusing on social determinants of health. The language might have been different, but the work was happening. And so it's exciting to see us get back to that now. So you can shift forward. So health inequities we see, I love this quote from Nancy Krieger, it's that health inequities we see are embodied in the expressions of social inequality. They're not just about individual bad choices or about things being fair. And for me, this quote really just reminds me about the fact that our systems aren't broken. They're not designed to work for everyone. And so how do we do that? How do we make them work for everyone? And how do we, and the way that we do that is by how the first speaker said, is that we involve people in the process. We involve families in the process. We involve our patients in the process of thinking about how can we do this better so that we're meeting everyone's needs. Click forward. Yep. So also can't be a social worker and not have a slide with the ecological model, although I'll show you another one. Just setting the stage, I think, for why social determinants matter is because, and I know I'm saying, just think it's naming what we know, is that individuals, families are part of broader systems. They're part of social networks, they're part of community networks, and within those systems there are organizations. And so the reason social determinants matter is because individuals are shaped by systems. At the same time, individuals are shaping those very same systems. And those policies, I think on this slide is not as clear as it is in the one I'll show in a minute, are informed by ideology as well, right? Policy is shaped by ideology, and that it trickles down to impact individuals. And so we need to keep that in mind when we're thinking about social factors as well, because those social factors are shaped by policies that are driven by ideology. So we can click forward. So again, here's so we're all on the same page. World Health Organization talking about social determinants of health, conditions in which people are born, grow, live, work, age. Right? They're the social circumstances, and they're shaped by the distribution of money, power, resources, and that's at the global level as well as national and local levels. And again, influenced by policy choices that we make. That's what creates living environments that our patients are sitting within. So you can click forward. And again, well documented the fact that social factors do contribute for the bulk of outcomes that we are seeing. You know, if you think here, and this is an older slide, I think there have been updated versions that account for up to 80%. Here, that the social economic, if we combine that with the physical environment that's also shaped by policy, we're over 50%. So environment shaped behavior. So just one last take home, right? This is my favorite ecological model. It's the ecological model that was designed for folks who are linear, in the sense that it's those nested circles are now more in a logical flow chart. But just, and this is from Schultz and Northbridge. It's an ecological model that thinks about environmental health promotion, but it really kind of, the reason I like it is that it lays it out in clear terms, the factors, how it is that these macro level factors sift down to the individual level, shaping environments, to the built environment, to the social context that surrounds that built environment, and leading to stressors to eventually impact individual outcomes and well-being. But it also lays out that important role of the ideologies that we heard the previous presenter talk about, as well as racism, justice, democracy, factors that shape how communities are constructed. And I think it's easy for us when we're thinking about social determinants to focus on addressing just those determinants and look at it without thinking about the role that the fact that we live in a highly racialized society plays in that. You know, the reality is that maybe we wouldn't see the gaps that we see if the conditions were equal across populations, but that different segments of our population, whether it's people of color, whether it's the poor, are experiencing different conditions. And I think that's important to keep in mind when we're thinking about the determinants of health. Um, so I'll click forward as well. And this, I just love this comic, right? So here's and we see this a lot. Here you have the scientist is focusing, we're looking under the light, right? So there's the old joke about a man who late one night dropped his keys in the middle of a dark parking lot, and he moves some distance over to the side of the lot, and he begins to fruitless search for them. And when asked, why are you looking at the light? Why are you looking here? He's like, well, the light's here. This is why I'm looking here. I'm looking under the light. Um, it's the cats are kind of like, well, the keys are really in this issue, the issues of poverty, access to care, environmental exposure, racism. This slide was actually given to me by a community partner of mine who's been working in the area of health equity since 1968. He reminds me all the time, telling me that you know, it's great that we're talking about determinants again. You know, we talked about them in the 60s. We're talking about them again, but we really need to focus on them. We really need to start to pull apart the big dark shadow that oversees the situation, the situation at hand when we're thinking about patient well-being. That if we're not talking about all of these things, we're missing a big part of the picture. So how do we get there, right? And how can we begin to think about addressing social determinants of health, particularly in the context of healthcare delivery? And so, you know, since the Patient Protection Affordable Care Act, growing literature focusing on the contributions of socio-environmental context to patient outcomes, we've brought this new attention over the past few years back to the social determinants of health, and we've heard that a lot in terms of screening. So here I have an example of a screener that's used. We use it at Boston Medical Center. It's a Thrive screener. It's based on WeCare, which some of you may have heard of. You can click to the next slide. And so where are we in the state of the science of screening? Where have we been and where are we going? I'll talk a little bit about that and kind of different approaches that have been used, but then I really want to focus the bulk of my time thinking about where do you begin? How do you, and most of you have already begun to jump into this, but we've seen a number of new papers emerging around screening and referral efforts specifically. Those started out, the majority of papers, if we go back and do a systematic review of the literature, we see that all early papers started out in pediatrics, family medicine. We've seen a number of papers since there's been more of a crossover into adult medicine, ambulatory care settings, and hospital settings doing more screening for social determinants of health. We've also seen shifts in medical education happening simultaneously, focusing in on social determinants of health, because it's one thing to think about how we're going to do this in our organization. It's another thing to think about preparing the next generation of workforce to continue to do work around the social determinants of health. That literature has been diverse. It's focused on providing education directly to medical students. We've seen a lot of interdisciplinary training with medical students and nurses together, training with medical students and social workers together in some settings as well, team-based trainings for medical students, simulations, really to think about how do we prepare folks as they're going in to think more holistically about health and to think about coordinating around care. within the group, within the team, less education seen around in the medical students with broader community stakeholders, but some as well. More around training nurses in the community. There's also been community partnerships as an increasing a way to increase access for or an increase for patients to access social needs. So we've seen um, healthcare delivery organizations partnering with community-based organizations, papers around that. And you can click to the next slide. Um, so I think it's important that there's not one approach, which is challenging on the one hand in the sense of in terms of the evidence. You know, do we know the screening is effective? Do we know research referral is effective? Can we, when everyone is doing it differently? But the reality is that healthcare organizations are complex, adaptive systems in and of themselves. And so we really need, sites do need to have some autonomy in terms of how they're approaching screening. There's also been differences in the literature in terms of who's doing the screening. So how the screening's been rolled out, who screens, and then with respect to connection, who's doing that connection to resources? How is that happening? Is it happening inside of the organization? Is it happening outside of the organization? Who are the healthcare professionals that are responsible for that screening? It's anywhere from medical assistants, providers, community health workers doing connections, social workers doing connections, nurse case managers doing connections. So it looks different in different settings. We see medical legal partnerships emerging. There's a lot of literature in that area, but there's agreement on that. One thing that is really clear in the literature is that not collecting data you're not going to use, and that to be saying that you can't just screen for the social determinants of health if you're not going to connect people with resources. And so that's one important piece is how do you actually link people to the resources that you're screening for. And so I see a comment in the chat as well. I'm just trying to see if it's a question. It's always a challenge monitoring the chat simultaneously.
Linda, this is Jessica. I've got it for you. So Meg Tracy just posted a really great resource on focusing on protective factors for Native youth and families. And there was just a point of sort of shifting from looking at a deficits-based approach more to an asset-based approach in Native communities.
Great, thanks. Click to you can click to the next slide. Yeah, there's a really great paper that came out by Gottlieb, and Gottlieb has published a lot. Laura Gottlieb has published a lot in this area around screening for social determinants of health. This is a group at University of California in San Francisco, and they talk about, they've looked at kind of some of the different strategies that healthcare systems are using around social determinant screening, and really thinking about that risk. They use a model where they call risk-informed care versus social risk targeted care at the provider level or healthcare systems level, and that social risk care informed care is kind of I would say a lot of the earlier efforts around really the things that healthcare systems are doing to advance clinical care by incorporating considerations for social factors that may influence patient care. So those are some of the things, and I think a lot of these things have been happening for a while around extending hours, putting in place interpreter services, some of, taking into account whether or not patients can afford medications. Those are all things that are really taking into account that there are social factors that are going to influence patient treatment seeking and coming into care, as well as, disease management on the other end. And then the social risk targeted care are really the strategies that are more recently we're seeing an increase in the literature around assessing for social determinants of health, connecting folks to resources, putting systems in place where maybe you put in voucher systems to, and those are most commonly voucher systems for food or housing or transportation in place. There's also, we see within that, there's, the care linkage to care. So sometimes community health workers linkage to care. There's different professionals in that role that might be connecting the patient to the actual resource, either through a warm handoff or just a referral like a list of a resource list as well. And then there's also been strategies that are more community focused. And so some of that might be through financial investments. So if institutions have maybe say, for example, community benefits dollars, they're going to target into a particular area. One example of that would be, you know, maybe thinking about if we know that housing is an issue, we're going to invest our community benefits dollars in affordable housing through a partnership. There's also been community-focused strategies where healthcare institutions are part of multi-sectoral coalitions or partnerships that are designed to improve patient access to services or to improve conditions in the broader community so they support patient well-being. But again, I think it's just in terms of research, there's not as much research in across these areas right now. There's a number of case studies that have been where folks are describing what they're doing, putting them out there, but there hasn't. There's still, as a researcher, of course, we always say there's need for more research, right? And so there are still limits in terms of what we know, because and especially with respect to connecting patients to resources in the community. Kind of what's the secret sauce? If I give someone resources, how are we going to ensure that they're actually connecting to those resources, particularly if you're just giving a list of resources, who's to say? And then keeping on top of that, because there are a number of challenges, making sure that there's someone that the patient can connect with within those resources in the community. But I think through the multi-sectoral partnerships, the model there is nice, is thinking about how can healthcare organizations partner with different sectors within the community to kind of shift change within the broader community when it comes to improving living conditions. What's the role of healthcare there? So you can click.
Linda, we do have another question in the chat. If I could just sort of draw your attention to Erica Jewell just asks, how does the top of license argument come into play with who, quote unquote, does the screening? She says, my staff and I feel that this should be universal, which means we don't have enough MSWs to do it.
You know, that everyone should be screened. And so how do you make sure that everyone has the capacity to screen and or to connect with resources? I don't know if Julie, Erica, oh, sorry. Erica, do you want to come and ask out loud?
Yeah, that was basically the point, right? So we have a certain number of MSWs that see inpatient, outpatient, but if we really want to screen everyone that our hospital and outpatient clinics see, it needs to be done at more like the medical assistant or registration level.
Mm-hmm. Mm-hmm. No, and that I think that makes sense. It's funny. That's the way when we were piloting. The screener at Boston Medical Center, when we first started piloting in 2015. One of the things that we saw is that in order to make it feasible, it needed to be piloted. If we were going to do everyone in ambulatory care, and we were just started in one clinic, but we needed the medical assistants. At registration, the patient was given the screener, and they were then followed up in the appointment. And so we saw that as well. If we were going to have everyone do it, the workforce that we needed to train to do the screening was that the registration, but every healthcare system is set up differently, and so that might look different in another setting in terms of who the person is that is doing the screening, and whether or not it has to be administered by someone or if folks fill it out independently also varied. But I think there are challenges to that as well. We did run into some interesting challenges, or whether or not folks were in the union and additional timing for training. So there's a lot of considerations there. I would also say that the who is going to look different depending on your institution and how your institution is structured and how what your workflow looks like. But the screener doesn't, based on the literature, the screener doesn't have to be an MSW, or it could be, it varies in the literature in terms of who is doing the screening. I don't know if that gets at your question.
There was a follow-up question also from Jeff Schiff about if there's been any research looking at cultural competency of clinic providers and systems and the ability to effectively screen and refer to services. So are there some models for implementation there?
In terms of, you mean measuring the, can you, I don't know if Jeff, you want to come on and speak to what you're, in terms of the level of cultural competency,
I
what you're
just,
getting at there?
sure. I mean, I really appreciate this conversation. I just want to be careful that we don't put a screener tool out and we have a lot of implicit bias or structural racism in our system. And we say, well, we screen for food because that's what we can refer to. And then at the end of the day, that's all that's left is somebody got screened for food when they're really desperate for housing
Yeah.
or transportation or something like that. Or the screener is doing this as a rote thing where they don't really feel confident. So I feel like we have, I don't want us to go down a road where we screen everybody, but at the end of the day, the people don't, either they get a referral that's meaningless or they feel like the institution is culturally or structurally inappropriate for them and they don't come back or they feel put off by that. So I think we have to both integrate or understand the structural racism and the implicit bias that our institutions come to and make sure the people who are doing the screening both understand the culture of folks and where they're at and their weakness, their challenges and their strengths at the same time um, move the resource question along as well.
Yeah, I really appreciate that point, Jeff, because it's you know, a screening isn't going to address structural racism, right? We know that from all sorts of other fields, and there's also, you know, there can be dangers when we think when we're screening as well because we think we're doing everything. Like we've done everything we can, we've checked, and the reality is, at the end of the day, you know, probably the most important piece between the patient and provider is their relationship and getting to know the patient. So right, and really getting to being able to connect with that individual on a human level. And so the screening is helpful in terms of reminding folks of the conversation that needs to be had, that there are other factors that may be influencing patient well-being, and there may be resources that you can connect them with. I have a colleague here in a community health center, and she's doing a lot of work around, you know, training providers to talk to patients about how racism impacts their daily lives, which is a different way to think about this screening for
Right.
social determinants. And so I do really appreciate that. We've had some last pre-COVID, I will say, before we became stuck in our houses. And we were doing some interdisciplinary training with social workers and medical students around the training. And one of the really interesting things was that that came out of the training was that medical students were asking the questions on the paper. Um, and social work students were really frustrated by the questions on the paper because they wanted to engage in a conversation with the patient. And so they would do the follow-up. We would do case consults between the medical students and the social work students. And it was very interesting because, you know, we were studying the process of how this plays out on my end. I'm interested in studying it. So, you know, is that the medical students and the social work students were, during the case consults, after the screener, there were so many questions still unanswered. And it just showed the need for follow up, that the screener is only going to get you so far. It's going to open the door to questions, but it's not going to answer them all. I'll also say that one thing that's important to consider is that even as you're developing your screening and thinking about how if screening is the way you're going to go, as you're capturing this data, it's important to work with not just your provider team or your implementation team, and I have this in some slides as we go forward, but you know, you want to incorporate patients in that process as well. When we were developing the Thrive Screener, we worked with patients and started talking to patients about what they thought about the screener. We spent a lot of time, like, this is the whole idea of screening, and that before we even got to the questions, to see where people were at with it. But it's really important to partner with patients and to think about how you're going to approach it, because you want it to be relevant for your patient population. And it's, you know, it's hard because patient populations are diverse. It's not going to be perfect for everyone, but I think having that continuous open conversation about how's this going, you know, more easily said than done. I realize there's a lot of folks involved in the process, but it's important. Any other
Linda,
questions before we jump forward?
Well, we have a lot more questions and
Okay.
comments. Wondering if you wanted to sort of push through with the rest of your presentation and leave some time for those questions at the end, or would
Sure.
you rather?
Yeah, I can push through. That's what the, yep.
Yeah, I think we
Okay.
have time at the end allotted as well, Linda. Your very last slide, we should give everybody, we have till 1:30 for you, so take your time
Okay,
with
great. Yeah, and I don't have, I mean, my next slides are a lot of questions for us to think about, so we can add
Perfect.
those to the list for follow-up.
Okay, sounds great.
Great. So where to begin? All of these different places we could go, all these different ways we could go. With no right or wrong answers either way. You can click forward. I think one of the key first things it gets to the last point is to oh, my slide got cut off, is to know your local landscape, right? There's so many assets within our institutions. There are folks. One of the things that, and we found this, and is that there are folks who are already partnering on the outside. There are folks within any given institution that kind of sit on the edge of the institution and the community, and they operate in both settings. There are folks who already have existing relationships. And so really, how is it that we can get to know what's already happening broadly within our institution to think about how do we move forward? So you can click to the next slide. You can click again. I got a little crazy with the animation here. Feel free to click a few times. So for internal considerations within your organization. So one of the things, the questions to ask yourself, are there existing programs or departments who are already working focused on, oh, you didn't have to click that far forward. Whoa. So
Sorry about that.
that's all right. Already doing work focused on social determinants of health. So who are the folks within your organization, or what are the programs within your organization that you can really begin to leverage, see what their lessons have been learned. What systems are in place that might help you capture and communicate data related to social determinants of health? You know, what is your EHR or your EMR, however you refer to it at your respective organization? How might you use that to think about collecting patient information and focusing in on social determinants of health? Who is the workforce and this came up already, but who's the workforce that's going to be responsible for assessing within your organization, or is responsible for assessing within your organization? What services might we already be providing to address social determinants of health, or partnerships might we already have? You can click. And then, here's just an example. It's not as clear on this slide as it was on my slide at home. But when we were getting started with Boston Medical Center, one of the early things we did was we just did a brainstorming session with the Mission Advisory Group to think about what are all the folks who might be doing something around social determinants of health. And we came up with a countless number. We surveyed all those different departments. Just a really quick and simple Qualtrics survey. We collected information kind of about the organizations. We collected information about who they were, what kinds of data were they collecting already, who their community partners were, how long they've been partnering, if they had formal agreements such as MOUs with their partners, if it was more of an informal agreement with their partners. But we learned about a number of different programs, a number of potential champions were identified through that process, and a number of external linkages were identified as well through that process, just to get us started, so that we can involve as many people from the organization in our planning as we were developing the tool, and get feedback from as many folks as possible as well. You can click forward. You can click a number of times again, thanks. That's what happens given academic time with slides and things get crazy. So then what are your external ties? Community connections, community partnerships. Where are you already connected and doing work in the community? What advice, maybe you already have, I'm guessing everyone has a patient or family advisory council. You have advisory boards within your existing organization. You have connections with community partners, maybe housing organizations, maybe local government. But where are you already tied in, and how can you leverage those ties to help think about screening and referral and getting your patients linked to resources to understand that broader context. You know, again, partnerships, MOUs in place. Some organizations might not want an MOU, a memorandum of understanding, or formal agreement. Sometimes some are more contractual, and some are much more informal, word of mouth, their personal connections. Although I always say that even if you have personal connections, thinking about ways to institutionalize them over time is helpful in case of any kind of transition planning or turnover. Who within our organization who within our organizational workforce is in a position to span boundaries, right? There are folks who do work in the community, there are folks who do work in organizations, but not all health professionals are working both internally and externally. It's also at that time, as you're thinking about who within your organizations, and I forgot to put it on the slide, but it's something that has gotten in the way. And has come up in the literature, is really what are the organizational policies you might have, right? And so sometimes there may be organizational policies that are in place that pose challenges to linkage services later on. So there may be policies around if you're going to do any kind of out connecting people directly in the community. There can be policies that regulate people's work that don't allow them to work within the community, or to bring people in their cars, or little things like that, that as you get further along, you want to be thinking about earlier, if you have a sense of the policies you have in place. And then I think also another point is to think about how might your data that you collect influence or benefit local advocacy efforts focused on social determinants of health. And this kind of fits in that category about multi-sectoral partnerships or coalitions, but sometimes in healthcare institutions, we collect a lot of data. You know, maybe we understand that housing is playing an important role in influencing patient well-being, and you know, it could be that and we might have data that we've collected on that through our assessments, and we've learned that systematically. It may be that local housing advocates are trying to make a case for more affordable housing, and our data from the healthcare system can be powerful, and not that we're out there doing the advocacy, but when there are data sharing agreements between healthcare institutions and local organizers or housing activists, it can help to kind of push forward their efforts, because maybe they don't have that same data that we have. So there are different ways that partnerships can help improve social conditions that we might not always be necessarily thinking about. So that's another important consideration. And then clicking forward. Thanks. Yeah, I think it's just as you're thinking about implementation, it's important, obviously, within your organization, and this gets a little bit of that point to the point earlier about equity and equity within the organization, or even thinking about structural racism and how it can play out in organizations. That really having a shared vision and a shared understanding around addressing social determinants of health, why it's important, how it plays out for patients, really to get that buy-in early on. How do you create that shared vision? Who do you need at the table? Identifying your champions, and then putting together an implementation team for your efforts as they're going underway, and really thinking about making sure that patients are part of that, family members are part of that team, establishing systems and structures for data collection or data management, ensuring data is accessible to providers, because you can screen for that data, but depending where it sits, is someone going to see it the next time your patient comes in? How are you going to make sure the systems are in place there? Do you need someone from IT to be part of your planning team as you're going to see how, because sometimes you can have a team that's ready to go, folks are ready to screen, but you get put in the docket. I don't know if folks experience this at their organizations as well. And it's going to take a while to make a change to the EMR so that we can actually collect that data. So that's an important piece to think about, who needs to be there, creating any kind of guide or manual, putting in loops for ongoing training and feedback. How is it going from the team perspective? How's it going from the patient perspective? and really thinking about, I would also say if I had something to add here would be to really document and share what you're doing and lessons learned. The literature in this area is still nascent, and so case studies of what's working for folks and what they're learning is really important in terms of advancing understanding broadly. So in your free time, so write a paper or find a student to write one for you. That's the key. And then to anticipate challenges. You can click. I had some cute graphics just one time though, right? So the bridge to nowhere. So this is kind of we want to be able to create. We want to be able to identify where folks are needing resources and really connecting them to places we can connect them to resources. We also want to avoid working in silos. The work around social determinants requires teamwork, and it requires multiple healthcare professionals at the table along with families, and really communication and holistic planning. You can click again. And then and not trying to do it all internally. I think in some cases we read, when I'm reading papers and looking through, it's really great when we can put resources in place within our institutions, whether we have a food bank within our institution, we have the transportation resources, but really how do we connect to resources in the broader community? How do we begin to create partnerships, to leverage resources that are available in the community, to share data bidirectionally between community members and the institution so that we're able to create something that's sustainable and has a long-term impact. So partnering is important. So those are not, don't avoid partnering. So partner, engage stakeholders, and then establish systems and put them in place. You can click, and you can click, I think, questions. You can stop there.
Thank you so much, Linda. That was absolutely amazing. We have until 1:30, so we can see if anyone has questions that will come through the chat. I'll hand it over to Jess to moderate, but then also feel free to turn your cameras on if you want to do a live Q&A session. You're welcome to.
Yep, and you can also, if you throw up your blue hand, then we'll know it. Like if you go to participants, there's a raise hand function, so we can see too if someone wants to share a question out loud.
Well, we have some in the chat. I'll just start there.
Okay.
So we've got a question from Beth from Alabama. So I'm just going to read it. But so what if there are not enough resources to address the issues? So if there's wait lists, funding is limited, how do you ethically do this? I'm assuming sort of get this information if you know you might not have a place to refer somebody. Beth, feel free to unmute if you wanted to add anything to that question.
I think you got it. Thank you, Jessica.
Yeah, I really appreciate that question, Beth, especially around the wait list. We have like 14,000 people on the wait list for public housing here in Boston. And so when we think about what are the resources, how can we connect folks? We screen for determinants around housing. How do we, the reality is we're probably not going to get someone housed right away, but what are the resources that we can provide? And that's the key part of when you're doing that initial assessment and understanding the community context is part of that. So you understand internally what's happening, but then understand the community context. One thing that, we were able to really highlight is there's a really great organization here in Boston, Vita Urbana City Life, but they do a lot of advocacy on behalf of folks around housing. One challenge we saw when we started talking to folks, well, what is the local landscape around housing, for example? And this is takes time, but we learned that it's not only just affordable housing, it's about the fact that people are being displaced due to gentrification. They're finding that their rents are increasing by $600. It's causing stress. It's these little nuanced things that we're finding. And so we're able to identify, well, what are the resources for that as well? So we identify legal clinics, we identify free housing advocacy that's available. There are, different types of emergency housing that are available, but we want to make sure we have a comprehensive list, which means that when we're screening, we're not just saying, well, we might screen around, is housing an issue? Is that something you want support with? So that's a way that we screen it. is based on the We Care form that we had started with adaptation, is that there's what are we screening for, and then what are you interested, is this something you want support around? And so when the person is going to the if they're getting the warm handoff to someone who can provide support around that, then it becomes a deeper conversation to really understand, well, what's going on with the housing? Let's talk about it. You know, you mentioned housing is an issue. So it's not just a question, well, we're going to find you housing. It's more of a question of what's happening in the context of housing. And more often than not, we're finding it's landlords are increasing rents by, $600 to $800 per month. And so that's something we can actually refer for so that something can be done about it. But we have to understand that full context, because then we might find out that, depending on a patient's status, that maybe they might not qualify for certain resources. So we need the assessment, and I think it gets back to that earlier question, it's just an opportunity to open a deeper conversation with the patient about the factors that are influencing their well-being.
So the next question we have is from Debbie Harris, and Debbie has a couple of questions in the chat. It looks like initially, Debbie, you were interested in asking Linda about how to screen for social determinants of health without reinforcing stereotypes, and then you kind of followed up with an example. Do you want to share that?
Yes, I just wanted to share from my own experience where I've sought just like advocacy service, for example, with a nonprofit organization. And I guess they were screening for social determinants of health, maybe just to get demographic data, to get for grant information or something like that. But it just kind of, before they would even serve us, they asked for that information and insisted on having that before even finding out what the situation or the problem was. And so it kind of set the relationship kind of ill at ease in the beginning, because it seemed like there are assumptions made about you, which with my experience in history is the very thing that you don't want to have happen. And so how do you go about screening without kind of putting forth this kind of notion that assumptions are being made about people? Mm-hmm. So I think we have to be really careful about that.
I really appreciate that comment, Debbie, because it's also this important reminder that, we can't use screening as a means to an end, right? We're not just collecting data for data's sake. That the one important piece behind trying to understand how social determinants of health are impacting patients is really to understand how we can provide the best possible treatment and make sure that people are getting what they need in terms of resources. And part of that is, again, thinking about screening as a way to really open the conversation with patients, to try to not just, what brings you here today, but also how can I get to know you, right? I want to understand you. I want to understand all of the factors that are influencing your well-being. And is there anything beyond what you're, maybe presenting with that we can provide support with? So I think I think that's it's a really important point, that we want to make sure that we are. One of the ways that when we're talking about it is we say that there's a lot of different things that can impact health. If you think about it, there are things that we worry about. If we're our employment can impact health, all of these different things. And so part of what we want to do as a health center is really understand what are the different things that are impacting your family's health and well-being. And there may be some additional things that we can support with as a health center. So I think it's really just building the relationship there. But I really appreciate that comment, Debbie, on a personal note and as a researcher, after having been referred to a program once by a hospital that it was not helpful, and an assumption that they had about who I am. So,
thank you.
Yeah.
So thank you so much for that question, Debbie. And just moving into some of the additional resources that were put into the chat. I know we started talking a little bit, Meg Tracy, you had mentioned the protective factors in American Indian and Alaska Native populations. Did you want to speak to that at all and just sort of focus people's attention on that piece in the chat?
Sure. This is Meg Tracy, and I would just thinking about the opening remarks about strategic planning, and that it does take a multi-level approach if we really want to be thinking about social determinants of health, so that we can be working with the resources available while also working upstream with partners of marginalized communities to increase the resources from their perspective, and with the priorities of those communities in mind. So just thinking, about the space that we're in Montana, and that it's hard to move things forward without creating some real change in how we organize to address priorities. And so just thinking about how we I'm thinking about, in my mind, as everybody's talking, I'm thinking a lot about Kamara Jones and her work, and how we really become co-conspirators. And the strategic plan, I think, allows us to do that, to be working at the direct service level on information and referral with what we have, but then also working at those macro levels to change how we network, how we partner, and then how we organize priorities, so that we are thinking with indigenous communities about the real need to go back in time and repair. There's a lot of harm that we did with, for example, the fetal alcohol syndrome and fetal alcohol exposure agenda with indigenous people. And there's a lot of work to go, even further back in terms of the experience of Native people in really strengthening those communities so that they can be leaders. So that's all I'll say. Maybe others have stuff to add.
I think that's such a great point that you make, in that how do we, the being intentional, right? That we can't just jump in to another tool. That's our first reaction, is always to quickly develop something and get it out there, but really being intentional, understanding local landscape, understanding historical conditions that will influence how people respond to you asking them these questions. Because I just came here to get this fixed, and now you're asking me about my housing. What do you want to, that's real. Given some of the historical relationships between healthcare institutions and community members, particularly in among marginalized community members. And so being intentional and then being inclusive, creating space for families to be at the table as you're developing, and putting together teams, implementation teams as well.
A couple of folks
I just think the one other quick point is, and you probably all see this in your work, that when it doesn't go well, like, bad news travels fast in communities. And so if it's not done well and intentionally, word will get out. And so, but when good news also can travel fast, just not as fast as bad news sometimes.
A lot of folks echoing that in the comments. I think I see Nick was saying here that working with families on resource needs, it's imperative to be honest about what may be available and what probably will not be available. Raising expectations unreasonably is potentially very harmful in terms of building a relationship. And then we also have Christine from Indiana saying it's very important to be clear and ensure understanding when it comes to offering resources, and families appreciate honest and genuine support and can easily feel misled when resources are offered but not actually available. Those are excellent, amazing points. Thank you guys. Did either of you, Nick or Christine, want to say more about those comments? Okay, no pressure, don't have to. Those are really great anyway.
No, I couldn't get the thing to unmute. Yeah, just basically that, I mean, it's like when you ask families to take part in surveys and focus groups and stuff, you've got to be honest about what it's all about. You know, basically what's in it for them, to put it bluntly, because there is nothing worse than screening for something that you know isn't available. So one thing you can do is, you know, before you give someone a resource, you know, for something that looks wonderful on paper, because if you go onto most agencies' websites, it all looks absolutely fantastic what they can offer. Oh, we can do this, we can do that, we can do the other. But when you actually call them, they say, well, we can sometimes, but we're out of money now. So it's important that whoever is facilitating the discussion and has a relationship with the family, check out, you know, what will this family hear if they do call, you know, if they call the number we suggest, what are they going to hear when they get through? So there's a lot of pre-work has to be done by ideally social workers, being biased, and then that can help build the relationship so you really can get to some of the other issues that may be there, and of course they may not be there either. So I just also wrote, Florence Hollis wrote once, if a family asks you for a blanket, you give them a blanket, you don't try and psychoanalyze them.
And I'll just add to that, you know, this is Christine from Indiana. I'm sorry, I can't have my video on. But it is, you know, when you offer to families, we have to consider that the families already probably have jobs. They have possibly other children that they're caring for, and it can be a full-time job just to make sure that this child that, you know, they is getting the care that they need, let alone then having to seek out the additional resources. They don't have a lot of expendable time to be able to doing and looking into and participating. So that really needs to be a part of the consideration.
Thank you, everyone. I just want to acknowledge too, Marie Mann, I believe you had your hand up. Did you want to speak?
Hi, I have a question for Linda. I think at the beginning, when we were looking at different models, one of the things is really talking about how policies contribute to some of those factors that impact patients and families. And I'm particularly thinking about the public charge rule, and what has been your experience in how and potentially the value of identifying trusted individuals in the community to work with you, the team or whoever, to at least ease some of those fears. And because there's such a challenge, I think, even if the resources are available to reach those individuals and families who probably most need that assistance.
Yeah, and I think, and I really thank you, Maria. I really appreciate that question, because I think one important first point is really helping providers. Not all providers even understand the public charge rule or might be familiar with it, especially thinking about some of our residents and folks that just think making sure people understand that families are worried about that. There was a really great article that came out. It had some colleagues, we're in the next town over, not in Boston, they're in Everett, but given the current climate, they've done some work to look at how even just the climate around immigration broadly impacts treatment seeking. And they found that it was delayed and deferred as a result of fears for folks, because at one point we had an uptick in rates that were happening here. But I think that really it's important to understand what are the safe spaces in the community, because sometimes we think the community as if it's this unit of all that is good, the community, but there none of us are immune to the impact of white supremacy culture, internalizing it within our organization, or structural racism, just because it's the air that we breathe, right? We're all living in the same world. And so some organizations aren't as safe for community members to go to. They don't go to them because they don't feel safe. And so really understanding who the community leaders that are trusted within the community, where folks are feeling safe, and kind of connecting with them, linking, it's a bigger process, right? Because then making sure they have the resources they need to be able to engage with patients as well is important. And working collaboratively. But that's part of understanding the local community landscape is who are the trusted resources in the community, who's safe for what communities. And I think a challenge for healthcare delivery organizations is that there are so many communities or segments of the population that we're working with. And so really understanding that local landscape requires that we have partnerships and resources to help us to do that. And it gets back to Nick's point too about even it makes knowing like what's going to happen when that person links with the resource. I remember a provider telling me, well, I gave him the resource list of like, did you call any of the resources on the list before you gave it to him? You know, and is there, I could call that and know that there's no one who is Creole speaking or Spanish speaking at the other end of the line. There's a voicemail. There's, you know, so there are also, it's also kind of working with our partners to set up systems that allow our patients to access them. So thank you.
Excellent. Thank you so much, Linda. I just want to be mindful of time. I want to get you guys all to your first break as we have a very busy day planned for you after. I know there's lots of other questions and comments through the chat. I will do my best to try to answer some of those after today through email, and can also connect. Linda, I might field some of those questions with you, and then I'll answer the participants later on. Thank you guys so much for making this interactive, though. It's been great. We will resume at 1:40, and Renee Turchi will be giving our next presentation.